Welcome to the Motivational Midwife. My name is Lynn Jones, and as part of our Putting It All Together series, we are looking at the liver today in preparation for a different video on obstetric cholestasis. So let's look at the liver. Okay, so really the liver is an amazing organ. It really is one of the most fascinating organs to think about. It regulates most of the chemical levels in the blood. All the blood leaving the stomach and the intestine will pass through the liver. And what it essentially does is it processes, it breaks down, it balances, it creates nutrients. It can metabolize drugs into forms that are either non-toxic or easier for the rest of the body to use. You know, in all, there's more than 500 vital functions that have been associated to the liver, and we're only going to look at just a few of them. So about 13% of the body's blood is in the liver at any given moment. Okay, and it's made up of two lobes, one larger and one smaller, and each of those lobes has got 8 segments and then thousands of tiny little lobules which are connected to ducts that interconnect with larger ducts and form that common hepatic duct, whose function is really to take bile from the liver to the gallbladder. It has 2 separate blood supplies, so it gets one blood supply from the portal vein, which is rich in nutrients, and then the hepatic artery will bring oxygen-rich blood into the liver. And all the blood will leave via the hepatic vein. And as I said, we've said the common hepatic duct transports that bile from the liver to the gallbladder and the first part of the small intestine as well. So looking at the functions of the liver, so one of the main functions is that production of bile as well as sort of proteins for blood plasma, but the bile helps carry away waste and break down fats in the small intestine as part of the digestion process. And the production of cholesterol and special proteins will help carry those fats through the body. The liver also is involved in converting that excess glucose into glycogen, which it stores until that energy is needed, and then it can release that energy. And that is really what's key in that balancing and production of glucose as it's needed. The regulation of amino acids, and that's the sort of they're the main building blocks of proteins. Processing hemoglobin, okay, and distributing its iron content. Okay, so the liver stores iron. Conversion of ammonia to urea. So urea is one of the end products of protein metabolism, and it's what we're weeing out when we pass urine. There's urea in that urine. The liver will help clear the blood of drugs and other toxic substances, or as we said, it'll break them down into a form that is easier for the body to either use or make it non-toxic. It regulates blood clotting. It helps by making immune factors that will help us resist infections, and also has a part to play in removing certain bacteria from the bloodstream. And it's also responsible for the clearance of bilirubin. And if you get a build-up of bilirubin, It's that that causes, certainly in adults as well, the yellowing of the skin and the sclera of the eye. So very similar to the neonate, when the neonate becomes jaundice, but the pathophysiology is slightly different. Okay, so when we take a liver function test, what exactly are we looking at? What makes up those liver functions? So there we're looking at bilirubin, albumin, total protein. We're looking at the transferases, so that's your ALT and AST, your gamma GT, creatinine kinase, calcium and corrected calcium, as well as your prothrombin time. So how long does it take for the blood to clot? So when we have somebody that's pregnant, there will be, to some extent, some changes to those normal levels. Okay, so although we know that there's 50% more circulating volume in pregnancy, the actual blood supply to the liver remains around that 13%, okay, where it doesn't increase particularly greatly. However, the gallbladder, the motility of the gallbladder, so that's that motility, that sort of peristalsis motility, is reduced during pregnancy, and this will be primarily due to the effects of hormones, particularly as like progesterone. Progesterone relaxes all the smooth muscle, if you remember. There's decreased albumin, and that is mainly due to hemodilution, because we've got that 50% more circulating volume, so everything is hemodiluted. The alk phosphase is increased, but only towards trimester 3, and really that's down to, it's a more placental origin because of fetal bone development. And alpha fetoprotein, and this is one that's looked at often when you're screening for things like spina bifida, and that's increased because it's produced by the fetal liver. Our total bile acid concentration and some of those serum alanine transaminase, so ALT and AST, essentially. They're really quite hard to say, which is, I can see why we always just keep them as initials. All of those ones should stay roughly within a normal non-pregnant range. So if you are getting variances in these, then really you need to investigate further. Our clotting factors increase, and we know that the clotting factors increase because that's why pregnant women are more prone to getting venous thrombus, so deep vein thrombosis. And the thrombin time and APT should be within the same normal non-pregnant limits. So in pregnancy, if you get elevations in any of those, really that is abnormal. Okay, so we need to differentiate when you have abnormal readings between non-pregnancy related liver disease at any point. Okay, so non-pregnancy liver disease can happen at any time, whereas pregnancy related liver disease tends to be trimester specific. So things like hyperemesis is a pregnancy related, it's not true liver disease, but you will get abnormal liver function tests in about half the cases. The most common one that we deal with is our intrahepatic cholestasis of pregnancy, and that tends to happen in the late second and third trimesters. And then our other one, of course, is PET with liver involvement, so those that have got HELLP syndrome and acute fatty liver of pregnancy, and they tend to happen later in the pregnancy rather than earlier. And certainly PET is very unusual pre sort of 20 weeks. And pre-existing liver diseases, we're looking at things like hepatitis, chronic hepatitis B and C, and cirrhosis of the liver and portal hypertension tend to be the people with these. It's very unlikely that they will be pregnant. It's quite unusual to find these people pregnant. So liver function tests are blood tests that really look at how the liver is functioning, if there is any damage to the liver and biliary system, including those hepatic bile ducts and gallbladder. They also provide some insights into the coagulation, so how clottable the blood is, how the hemolysis, so how much the cells are breaking down, the nutrition, bone turnover, and a number of other conditions as well. And why do we worry about them then? So really, if we have abnormal LFTs or liver disease in any way, there's often very poor outcomes for mother and fetus, or both. There is an increased risk of spontaneous and also iatrogenic preterm labour because if the levels are very high, because of the risks of things like stillbirth, we often induce these women as well, or offer induction. So we are often delivering babies earlier than they would normally have come. And then, of course, with that comes increased NICU admissions. So all of this is useful background information for you when we look at our next video, which is focusing very much on obstetric cholestasis. And there you have it, a little insight into the liver, and I hope that's prepared you for our next video on obstetric cholestasis.